Good evening, everyone. Thank you for joining us tonight. Welcome to the Evexia webinar series. Our topic for tonight's special webinar is GI360, Extensive Assessment of the GI Microbiome. My name is Joanne Iverson. I'm the Director of Client Relations for Evexia Diagnostics and will be your host for this evening. Tonight, I have the distinct pleasure of being joined by an exciting guest, Dr. Julia Malkowski, who will be our presenter for this webinar. Dr. Julia Malkowski enjoys empowering individuals via docere to teach, to delight, and to move. Upon experiencing the excellent results of restoring the health of her infant son, Dr. Malkowski has began her career in naturopathic medicine. Dr. Malkowski graduated with a doctorate in naturopathic medicine in December of 2017 and a doctorate of chiropractic medicine in April 2016 from the National University of Health Sciences. Dr. Malkowski has presented at the International College of Health Sciences, of Integrative Medicine, the Institute of Women's Health and Integrative Medicine, and the American Academy of Anti-Aging Medicine. Dr. Malkowski has been published in the American College for the Advancement in Medicine and the Townsend Letter. She remains committed to optimal health on a personal level and professional level as a staff doctor in the Clinical Education Department at Doctors Data, Inc. Joining Dr. Malkowski this evening will be Dr. Wayne Sedano, our Director of Clinical Support and Education at Evexia Diagnostics. Additionally, Dr. Sedano is the Director of Integrative Medicine Education for the College of Integrative Medicine and lectures and teaches internationally. Before we begin, just a bit of housekeeping. We encourage participation. So if you have a question, you may submit your questions in the questions interface in the right-hand area of the interface. We will answer submitted questions towards the end of the presentation. In addition, the slide deck is also available in the handout section if you want to download that to be able to follow along. If your questions are not answered this evening, you will surely receive an answer by email within a day or two. So without further delay, I will now turn the webinar over to Dr. Malkowski.
Thank you so much. I sincerely appreciate that. And thank you to Evexia for allowing this opportunity to talk about the GI360. And thank you to everyone for your attendance today. So today we are going to be talking about GI360, extensive assessment of the gastrointestinal microbiome. And this is a fascinating topic, especially as we see the gut microbiome is becoming so prevalent in health and medicine these days. So let's dive in. So Doctors Data is currently bridging the diagnostic gap, and we will take a look at the details regarding the GI360 testing. And the interesting thing right now is we are at a time in medicine in that we can really use these tools and biomarkers to understand the foundational components of the microbiome. Historically, Hippocrates, the father of medicine, stated all disease begins in the gut. And now we can understand how that does function. And while we know not all disease begins in the gut, we do know there is a significant connection between the gut microbiome and our health. We also know that patients are really suffering from gastrointestinal conditions, and you see this in your clinic, probably on the rise. So we're using this test, GI360, to bridge the gap, the diagnostic gap, and we will talk about the different components of GI360. One of the methodologies is going to be the PCR-based molecular testing. This is very popular now with the advent of DNA technology and DNA testing. So GI360 is using PCR-based molecular testing in two aspects of the report, so we will see that. We are also using traditional microbiology. Many people don't know that microbiology is still very important with regards to bacteria. It is still the gold standard. So Doctors Data is an expert in that area as well. And we're also using this technology to understand dysbiosis in the microbiome. As we learn more and more collectively about the microbiome, we do know that a dysbiotic gut is associated with a variety of adverse health outcomes, including, but not limited to, IBS, IBD, GI complaints like constipation, diarrhea, but then there's other conditions as well, such as metabolic syndrome, obesity, diabetes. So we want to understand this information as well. Of course, we're going to take a look at GI pathogens because you'd be remiss to look at a stool sample and not understand, do we have any pathogens there? We see this very prevalent C. difficile, and we want to take a look and see if that is there as well. GI360 brings you a standardized test to profile the microbiome. The good thing about GI360 is you can see a validated scientific test to understand how your patient's microbiome compares to a normal biotic reference range. GI360 is also including the state-of-the-art stool chemistry tools. So this is biomarkers such as fecal lactoferrin, fecal lysozyme, fecal calprotectin, secretory IgA. Those important markers, including short-chain fatty acids, are included as well. And an interesting thing about GI360 that's unique is that it includes susceptibility testing to cultured isolates. This helps to guide treatment. So when your patient has a dysbiotic bacteria or yeast in their stool, we will take that isolate in the lab and in vitro provide susceptibility information directly for that sample. So this is another chance for individualized medicine that is so important in functional medicine. Together, this provides clinically actionable results. And really, we are bridging the advent of the scientific understanding of the microbiome alongside clinical practice with the GI360. One unique aspect of GI360 is that dysbiosis index. Now, you will see the dysbiosis index on your report, and the great thing about GI360 is the background information is here, that this is highly laboratory validated. The dysbiosis test is an aspect of GI360, and this is a PCR portion of the test, and this allows the identification of a normal biotic reference range and characterized dysbiosis. With regards to the dysbiosis test, you will see this on the report. Scores go from 1 to 5. 1 and 2 are healthy, normal biotic guts, and then 3, 4, and 5 are dysbiotic guts. Now, the background is that this is a highly standardized, validated, and CE marked stool test. CE is the European Union equivalent of the FDA. So that's very important when we're talking about stool testing. We want these validations. The great thing about the dysbiosis index is this is used in multiple clinical and research laboratories all over the globe. This is highly reproducible. It has the less than 5% confidence variability. So in terms of repeatability, meaning every time you run that dysbiosis index for the same sample, you will get the same results. And then reproducibility, meaning if you have your patient's sample and you send it to one lab and you send it to another lab, you will get the same results. It's very important when you're using laboratory testing and biomarkers to understand the validations behind them. Continuing on about the dysbiosis index, this is a highly defined population. The way the dysbiosis index was developed, there were over N of 1,000 patients. Right now it is over that as well because we're continuing to study and understand this information. And this test is utilized to differentiate key microbiome differences, and these were studied in highly defined criteria such as IBS and IBD using the Rome criteria. So these are highly defined populations. And you can see here that for dysbiotic individuals, 74% had IBD. So that is a high amount of the IBD individuals had a dysbiotic gut, where only 26% had the normal biotic gut. There's always variations in the gut microbiome, but we want to understand as much as we can about patterns. For IBS patients, 73% of those had a dysbiotic gut. And then for the healthy individuals, and those are individuals that have not been diagnosed with IBD or IBS, 16% had a dysbiotic gut, where 84% had a normal biotic gut. So 84% of those individuals have a healthy, normal biotic gut. Now, you might wonder, well, why do some healthy people have a dysbiotic gut? Well, as we'll see, there are other conditions and dietary considerations that can be associated with microbiome dysbiosis. It's not just IBS and IBD. There's actually quite a few fad diets that we do find a dysbiotic gut in, and that's a larger discussion than what we can get into today, but it is interesting to note that individuals on some fad diets, such as carnivore and ketogenic, do present with dysbiotic guts. So this would be a good piece of information for those patients on those fad diets, is to actually take a GI360 test, look and see what their microbiome looks for biomarkers and things of that nature. So that's another application for the test. And you can take a look at our website, www.gi360.com. You have access to over 20 peer-reviewed articles, as well as posters and abstracts. And this will show you the validations and the information on how GI360 has been studied. And maybe you're not going to look at this every single day when you're looking at the GI360 with your patient and interpreting those results, but you can rest assured that this scientific data is there and you do have access to it. All right, so now let's take a look at this beautiful beginning page of the GI360. The first page of GI360 is really a summary of the entire report. So this is an excellent piece of information. This is a place to start. And really, if you want to, you could just look at this first page with your patient, depending on how much time you have with them. The way the test is organized, it starts with broad-based information, and that is phyla, and then we look at the dysbiosis and diversity indices, and then we get detailed information that will follow about functional guilds and unique findings to the report. The first piece of information is the microbiome, your patient's result, graphed on the normal biotic reference interval, organized by phyla. So what we see here are the main phyla of the human bacteria microbiome. Starting at the top left corner, we have the actinobacteria, and then moving clockwise, we have the Verruca microba, the Tourniquetes, and the bottom right corner is the Proteobacteria, and then the bottom left corner is the Firmicutes, and then on the right side, we have the Bacteroidetes. Your patient's result is that white web, and it's graphed on that green hexagon there. So a perfect result would be that green hexagon. If the web is pulled in, that shows decreased abundance of that phyla. Example, the top left corner in the sample, Actinobacteria, that's pulled in, so that shows decreased abundance of that Actinobacteria phyla. Same for the bottom left corner, for Firmicutes, that's pulled in, so that designates, again, decreased abundance. Conversely, the Bacteroidetes, the left side there, is pulled out toward the red, so that's elevated. So we know that this patient has a disrupted microbiome abundance, and then also diversity is moderate, I would say. So this is a little bit, it's not exactly making a hexagon, but this is fairly reasonable. You will see on these reports, depending on your patient's results, sometimes you will see it very teeny tiny pulled in. You'll see triangles, you'll see squares. You can see some very dysbiotic guts here. And this is a perfect illustration opportunity for the patient to understand their report, right? So they can take a look at this and they can see their abundance and diversity very clearly. The next piece of information is going to be that dysbiosis index score that I was previously discussing. So the dysbiosis index score, as I mentioned, goes from 1 to 5. 1 and 2 are healthy, normal biotic guts, and then 3, 4, and 5 are dysbiotic guts. Again, that has been studied with regards to IBS, IBD, obesity, diabetes, and you have access to those papers at the website. We will find more and more conditions associated with this. You know, the chronic disease, metabolic conditions, chronic metabolic conditions really do take root in the gut microbiome. The next piece of information you have is the diversity score. Diversity score is one of the most fascinating scores with regards to the gut microbiome and human physiology. It's quite fascinating that if you take a look at PubMed, you will see articles that have studied gut microbiome diversity in relationship to immune response to COVID, in relationship to hypertension, in relationship to anorexia nervosa, extroverted behavior, so a variety of conditions. Now, to put it simply, the gut microbiome is very similar to any ecosystem in that diversity is representative of a healthy ecosystem. So example, if you were taking a walk down in your neighborhood and you were visiting a green space, you would like to see a variety of flora there. You'd like to see many different plants and hopefully animals and things like that. So the ecosystem of the colon is like that. You want a variety of bacteria. Generally speaking, that the higher the diversity score, the healthier the outcomes. So here you want a score of 4 or 5, and score of 1, 2 is below, and then 3 is moderate. Again, the diversity score and dysbiosis score, those are based on the 45 different bacterial analytes, and this is computed into an algorithm here to represent where your patient stands with regards to the normal biotic reference range. Okay, so that is the first pieces of information on GI360, and this is about the microbiome. Here again, we have the information about the dysbiosis and diversity scores. Again, this dysbiosis score, as we discussed, has been studied in over 1,000 subjects, and then there was recently a follow-up study of over 600 subjects. So again, the scores are validated. So when you are looking at this with your patient, you can understand that there's a lot that goes into that. The next piece of information on GI360 is going to be the detailed information of every bacteria listed. This information is included and computed in that web and the scores. So you do have that information already represented to you. GI360 is utilizing multiplex PCR technology for the microbiome abundance and diversity portion of the report. We are looking at the patient's results with regards to the within reference interval and reporting this as below or above up to 3 standard deviations from the normal biotic reference population. As an example here, we see this keystone bacterium, fecal bacterium prognitzii, that is a very popular bacterium. It is very essential within the microbiome to support healthy mucosal barrier integrity, healthy butyrate production, decreasing inflammation. So you really want this bacterium within reference interval. Example here, you can see that it is -3. You will have, we'll go through some reports and you'll see that you can take a look at every single bacteria and its value line by line. And that information is also reported at the end of the report. But at the same time, again, there is a summary page. So you can get as detailed into the microbiome as you like. Here we also see the very popular Akkermansia muciniphila. This is probably one of the most popular bacteria of the moment. This is a very important mucolytic bacteria, and you do want to take a look at the value of this bacteria. You do not want it too high, but you also do not want it too low. So this is an important bacteria with regards to the microbiome, abundance and diversity, and physiologic outcomes. Here we see all 3 pages. So these are the 45 analytes that are computed into the web, the dysbiosis index, the diversity score, and then we'll also see the functional guilds. GI360 is introducing bacterial functional markers. Now this is to really emphasize the bacteria that play a significant role with regards to human physiology. Again, you can take time and look at every marker and all of the information that we have provided, but you could also take a look at the way the bacteria group together in terms of guild to create a specific function. In this regard, the first group is going to be the butyrate producers. So these are the bacteria that significantly contribute to butyrate production. When these bacteria are low, this is associated with inflammation in the colon. This is associated with loss of mucosal barrier integrity. This is associated with inflammation and immunology factors. You really want healthy butyrate in the human colon. The next group is going to be the gut mucosa protective bacteria. And again, we talked about Akkermansia, that is a key player here. And these are the bacteria that support that mucosal barrier integrity. You really want healthy mucosal barrier integrity. The body goes through great lengths to keep healthy mucosal barrier integrity, making 3 liters per day. So that is a very important physiologic process. We really want that there because, again, remember, the colon is where the external physiology meets the internal physiology. There's very important immune factors occurring at that junction, and mucosal barrier integrity is integral to that. The next group is going to be the gut intestinal health markers. Again, fecal bacterium praenicii is very integral here for its anti-inflammatory functions. And then the gut barrier protective versus opportunistic, that is the next group there. And this is looking at the powerful fecal bacterium praenicii as well as other bacteria that can actually increase when fecal bacterium decreases, these opportunists. With regards to the microbiome, we cannot necessarily isolate one bacteria when we're talking about the entire function of the microbiome because they do work together and it's a balance of an ecosystem. So here we're looking at the balance between the gut barrier protective versus opportunistic bacteria. But again, if those are outside the reference interval, you can think about mucosal barrier integrity, intestinal permeability, which may precede autoimmunity and things of that nature. So this is a very important matrix here. The last group is going to be the pro-inflammatory bacteria. And in this group, we have these inflammatory bacteria that are associated with inflammation. They love dietary excess fats, excess proteins. We see them elevated in standard American diet. So those are the factors there. When you are looking at your patient's report, all of this information is presented on the first page in the key findings section. So here you have the toggles that will tell you if that group of bacteria is imbalanced or within expected intervals. For the first group, the butyrate producers, you can see that those are imbalanced because that is yellow. So we know that the butyrate producers are too low and you want to support those butyrate producers. Same thing with the gut barrier protective bacteria. The intestinal health markers are within range, the inflammatory markers are within range, but then we see the gut barrier protective versus opportunistic are outside the reference interval. That functional guild information is presented here, and this is a great place to make a intervention. Let's talk about the PCR and culture for pathogens and flora on the GI360. We spent the previous time talking about that microbiome information, but GI360 has more information than just microbiome. This also includes traditional culture. Traditionally, culturing for bacteria and yeast is an excellent way to understand what is growing in your patient's colon. With GI360, we're culturing through a variety of different growth media to elicit the growth of the bacteria and yeast. And then we're identifying these via the MALDI-TOF library. The MALDI-TOF library is a worldwide library database of yeast, bacteria, and viruses. And so this tells us what is growing in your patient's sample. Additionally, GI360 is using PCR. Again, PCR is another way to understand the bacteria in the human colon. It is very sensitive, it is very specific, yet it is limited to the primer set. With PCR, you need to have a primer, and that primer is going to look for exactly what it will look for, example, C. difficile. This is excellent because it's very sensitive and specific, but it will only identify what it is there. So it's like fishing with a specific lure for that species of fish versus when you're using the culture methodology, it's like fishing with a giant net and catching whatever is in the ocean and then taking a look. So GI360 includes both pieces of information, traditional culture and PCR in one test. So what exactly is the role of PCR versus culture in the detection and analysis of stool pathogens? Well, PCR is highly validated to detect pathogens. PCR became very popular a few years back with the detection of the COVID virus. And actually, PCR is the way to detect a virus in the colon. You cannot culture a virus. You're going to use PCR to detect that. So GI360 includes PCR for pathogens. This is very sensitive and very specific. On GI360, all of those PCR probes are FDA cleared. So rest assured that you're using the PCR probes that have FDA cleared and validation. This leads to high sensitivity and reproducibility. This is a very sensitive test. It is not recommended as test of cure because it can actually pick up pathogens that after the resolution has occurred. So it was a very sensitive test. Again, the results are limited to exactly what's listed there, and we are looking for the common causes of acute gastroenteritis. Now, rest assured, because what we have listed is there, but we're also including culture, and then we're also including ova and parasitology for parasites. So you have the variety of information in one test. Here we have an example of the GI pathogens panel on the GI360. And as I've mentioned, this is viruses because we're using PCR to identify viruses. And then we're looking for pathogenic bacteria. And we're looking for 3 common parasites via PCR, Cryptosporidium, Entomobia, and Giardia. So this information is here. Regarding this page is designed for your patient that presents with acute gastroenteritis, and this is important information that can be very clinically relevant. Additionally, we are looking for parasitology by microscopy. And I know you probably have patients that have come into your clinic and they have done a parasite cleanse that they found maybe via social media, via a friend or something like that. That's not what this is. This is standard of care testing for parasites. This is the 3-day collection. So 3 stool collections on 3 separate days. This is an excellent test. We're identifying over 30 different parasites. Expert parasitologists are looking in this sample under the microscope for the ova and parasites. This is a very important test as there's a lot of different pop culture ideas about parasite cleansing and testing. This is not that. This is the CDC standard of care parasitology. So this is an excellent test for those patients that are kind of misled with what is being brought to the commercial market. So this is an excellent test. Again, this is why the GI360 is a 3-day collection, because that is standard of care, that this is to be collected 3 separate collections over 3 days. Additional information on GI360 under the microscope is going to be other markers under the microscope. A common finding here is going to be yeast under the microscope. Unlike parasitology, there is some information out there that might not be based in fact. So yeast is actually considered within normal limits in the human colon in some amounts. So we want to keep that in mind. While there can be yeast that is dysbiotic and causing symptoms in your patient, which you do want to treat, there also can be yeast within normal limits in the human colon. So we're looking at yeast under the microscope here. Now, keep in mind, GI360 is looking for yeast in 2 places. We're looking for yeast in that culture. That is going to be the first place we're looking. We're trying to culture the yeast that's growing in your patient's sample. If it's outside the reference interval, then we will provide sensitivities directly on that isolate. The second check we have here is under the microscope looking for yeast. If we do find yeast here, the differentials begin considering the patient's history and presentation, as well as that yeast culture. If there's yeast culture, we can consider that this yeast here and the yeast that's cultured reflect different parts of the life cycle. These yeast are non-viable, they are dead, while the yeast that's cultured is alive and living. Now, the other consideration is if there's no yeast cultured and we see yeast on here, we want to think about the patient's history and presentation. If they do present with yeast symptoms, then you can consider SIFO. This is one aspect of GI360 where you can have a clue about the small intestine. Remember, GI360 is a colonic test. We're looking at a sample that's derived from the colon, but we can get some clues about the small intestine, and this is one of them. So small intestinal fungal overgrowth may occur, and a sign here may be that we see yeast on the microscope and none on the culture. That's because it's growing in the small intestine, yet we find it dead in the culture here. Additional markers on microscopy that are relevant would be immune markers such as white blood cells. We also see red blood cells, muscle fibers, vegetable fibers, Charcot-Leyden crystals. Pollen is a finding as well that can be benign. You could see that sometimes in patients that have seasonal allergies as well. And then, of course, we're looking at macroscopic appearance. So don't discount that because that can be a biomarker as well. The color, consistency, and presence or absence of mucus. The next piece of information we're going to talk about is culturomics. Recall that culturing is still the gold standard of microbiology. Everybody likes to talk about PCR, and PCR is excellent, and so is culture. Culture allows for isolated organisms that allow for the standardized antimicrobial susceptibility testing. So you will see that at the end of the report for dysbiotic bacteria and yeast. Again, the neat thing about the culture is when we are using the MALDI-TOF library, we have access to over 14,000 genre and species of bacteria and fungi. So with regards to PCR, you will not find that library data set in a stool test available for your patient. So you have a great opportunity there to understand unique organisms. GI360 actually discovered a brand new bacteria a few years back, the Larybacter hongkongensis. So with the culture, the first step is culturing that and then identifying it via the MALDI-TOF. And the interesting thing with yeast here, there is over 180 species of yeast, over 95 are candida. So actually we're constantly updating this. The more we learn about the bacteria, the more that we're able to update this information. So it's quite fascinating. We're really learning a lot about bacteria these days. Here's a sample of the microbiology portion of GI360. That first section is going to be pathogenic bacteria. That will always be listed. Aeromonas through Yersinia will always be listed because you want to see if your patient has these pathogenic bacteria. These are the big bad guys. Now, the next piece of information is going to be the imbalanced bacteria. This can be anything that is really considered commensal within the human colon. They don't exert significant influence in the human colon, but we do have a lot of bacteria ubiquitous to GI physiology. So some of the bacteria in our skin, in our oral cavity, they make their way into the colon. And then if there's any dysbiotic bacteria, that will be cultured here, as well as yeast. Now recall, this includes aerobic and anaerobic culturing, and this is a unique representation here. So no two results I have not seen two results that are identical. This is going to be unique to your patient. Again, that pathogenic bacteria portion will be there, but the imbalanced bacteria, the dysbiotic bacteria and yeast, that is unique to your patient's sample. So this is an excellent opportunity for individualized medicine, that you have this unique information to your patient. The nomenclature here is going to be no growth. NG is no growth. There's no growth of the bacteria. And then 1, 2, 3, or 4 plus, that's standardized microbiology testing there. Okay. So here we see a sample in which the patient had many commensal bacteria. The commensal bacteria reporting is not restricted. It depends what is growing in your patient's sample. And you will see here this patient has a variety of imbalanced bacteria, and this is considered within normal limits in the human colon. Now, some of these bacteria you will note have a red line there when they get to 3 plus and 4 plus. Those are called value-driven bacteria, meaning when they are in lower populations in the human colon, they're commensal, they're within normal limits, but then when they are in higher populations, they can contribute to GI symptomatology. If they were growing in those higher populations, it would be kicked down to the dysbiotic bacteria section, and we would provide sensitivities. Now, here we have the yeast. Recall, yeast is within normal limits within the human colon at a small amount. So there are some yeast species here, 2 species of Candida and 1 species of that Rhodotrula, which is considered within normal limits. Yet that Candida albicans is too high, so that is considered above reference interval, and the sensitivities are going to be provided. Now, a great thing that Doctors Data has done is 2023 published the antibiogram. So what Doctors Data did is they were able to collect the data every single time that a yeast and a dysbiotic bacteria was cultured and then sensitivities were performed. That data has been collected and that is available to you as antibiogram data. So you can take a look at the antibiograms published for dysbiotic bacteria and yeast during 2023. There were over 10,000 samples and all of that information is collected. So you can take a look there and see the sensitivities for the bacteria and yeast if you'd like. Okay. So here we have an example of the susceptibilities. This is for the Candida albicans. We have natural agents, we have non-absorbed antifungals, and you have azole antifungals. Again, this is unique to your patient's sample. So in summary, the state of the art is combining these methodologies. We're using PCR analysis for abundance and diversity of key bacterial populations of the microbiome. And we're also using PCR for detection of pathogenic bacteria, viruses, and parasites. This is highly sensitive and specific. And then we're also using the comprehensive parasitology by microbiology. Remember, those expert parasitologists are looking under the microscope for the ova and parasites. GI360 also includes microbiology, stool culture, and MALDI-TOF for the identification and standardized susceptibility testing of cultured bacteria and yeast. GI360 also includes a broad range of biostoichemistry markers that can be used as biomarkers. One of the questions for GI360 is which profiles should we start with? I would recommend starting with the GI360 because that has all of the pieces of data in one test. Then what you can do is, depending on the positive findings on that report, you can treat your patient and you can reorder a smaller profile such as GI360 Essentials or GI360 Microbiome. So you do have those options. Now let's take a look at some cases. Our first case is a 23-year-old female, and this individual has a history of GI complaints of unknown origin, and I'm sure you see these patients in your clinic. We know that gastrointestinal complaints are increasing, and we also know that there tends to be higher in the female population. This woman has been to many doctors, including a gastrointestinal doctor, and that was determined within normal limits, so there was no treatment recommendation for this patient. So she wanted to find out, actually understand what is happening with her microbiome. Of note, the patient is on the standard American diet. As we know, the standard American diet is associated with a variety of adverse health outcomes, and this is predominantly associated with processed foods, and this also may overlap with emotional eating. So that's something to pay attention to for your patients as well, because this is consisting of caloric dense and nutrient deficient food items. Let's take a look at her GI360. Wow, what do we see right away? The first thing we see is this web for her microbiome. Remember, we want that web to be right on that normal biotic hexagon range there. We can see that first left, the actinobacteria phyla is very low, the Verruca microba is too high, Trichides is too high, Proteo are too high, Firmicutes and Bacteroides are too low. So right away, I'm thinking about the constituents of this phyla. Actinobacteria, they really like vegetables. So this patient is, I would think about, she's probably low in vegetables. Verruca microba is too high. Now that Verruca microba, again, that's going to be the Akkermansia muciniphila is in that category. Akkermansia muciniphila is an excellent bacteria, but when it's too high, it can consume the mucus barrier. So we do not want it too high. We want it within range. The interesting thing about these mucin bacteria, these mucin degrading bacteria such as Akkermansia, they kind of cropped up once individuals started eating less soluble fiber and more processed foods. These bacteria have actually increased in population in the human microbiome. So this is an important bacteria, but we do want it in balance. And then the bottom right-hand corner, the proteobacteria, those bacteria, they love excess fats, they love excess proteins, they like the standard American diet, and we do tend to associate these with inflammation. So right now, we can explain to the patient based on that web what's going on with her microbiome. But let's take a deeper look. The next pieces of information are going to be the dysbiosis index and the diversity score. The dysbiosis index, again, goes from 1 to 5. 1 and 2 are healthy, normal biotic guts, and 3, 4, and 5 are dysbiotic. The patient has a dysbiosis index score of 5. So that makes sense based on her history and this finding so far. You know, and we know that the dysbiosis index has been found in patients with obesity, diabetes, IBS, IBD. So we do want to consider this for the patient in regards to other biomarkers, including lipid panels, glucose metabolism, things like that. We want to put these pieces of information together. The next piece of information we see is the diversity score. Recall, scores of 1 and 2 are low diversity. So we can see that with the web, right? The web is really tilted towards one side. Easy to see that diversity is disrupted there. So what can we do for this patient? Let's take a look at the key findings. Now we have two columns of key findings. That first section is the butyrate producing bacteria, and then that second section is additional findings. I just want to be clear here that that line, that first row, second row, third row, they are not directly connected. So the fact that it says butyrate producing bacteria and then it says butyrate low, yes, those are connected, but it's not printed that way, okay? So the second line, gut barrier protective, total short chain fatty acids low, that's independent information. That first piece of information, that key findings, we're still talking about that microbiome information. Now we're looking at the specific info about functional guilds. Remember, the web is broad-based information. We're talking about phyla. Then we're getting more detailed. We're looking at these computed algorithms, dysbiosis, diversity. Then we're getting very detailed. We're looking at functional guilds of bacteria. That first group, butyrate producers, outside the reference interval. This patient needs soluble fiber to feed the butyrate producers. That's very important. Now, the recommendations are really 8 to 15 grams of soluble fiber per day. There's some nutritional research saying that we should actually even increase that. That is soluble fiber. That's not total fiber. So total fiber is going to be, again, that 30, but maybe some research is saying now 40, maybe for men 50 grams of fiber per day, of which roughly a third, so 8, 10, 15 grams of soluble fiber per day. That's going to be red kidney beans, lima beans, chickpeas, Jerusalem artichokes. That soluble fiber will feed the bacteria and they will ferment that to create butyrate. That is the way to support these bacteria. The next piece of information we have is the gut barrier protective bacteria. That is within range. The gut intestinal health markers are lower, so that fecal bacterium is too low. We're thinking that there can be subsequent inflammation in the colon, so we want to support that as well. And then the inflammatory bacteria are too high, so we want to talk about the dietary inputs. Unfortunately, the bacteria in our colon do rely largely on dietary substrates, and so remediating that standard American diet is going to be very important for this patient. And then the balance between the gut barrier protective versus opportunist bacteria is outside the reference interval. So we know that fecal bacterium is going too high, and then those other bacteria, fecal bacterium is too low, and then those other bacteria are too high. We're creating a microbiome imbalance there. All right, so the next piece of information we have are additional findings, and the first piece we have is butyrate is low, total short chain fatty acids are low. What we can see here is a patient that is simply on standard American diet causing a disruption in the microbiome that is leading to dysbiosis, low diversity, low butyrate, that can lead to a variety of other considerations. So you want to intervene here and help this patient. This was a great biomarker for this patient to understand what is happening with her microbiome and to remediate here. Let's take a look at the details. Again, we see that actinobacteria are low. Actinobacteria, this is the second page, actinobacteria, actinomycetes, and bifidobacterium, those are all low. This is important. We want to feed these bacteria with vegetables, actinobacterium, actinomycetes, and then the soluble fiber for the bifidobacterium. This is going to be important. I mean, these bacteria are really involved in a variety of physiologic implications, glucose metabolism, vitamin metabolism, very important bacteria. So we want to help this patient, feed this patient the proper dietary substrates. Bifidobacterium is available as a probiotic, and that's fine. You can do that. You want to make sure that that probiotic actually can survive digestion and make it into the colon, and then you want to also feed it the substrate. So it's very important to use the prebiotics alongside those probiotics, okay? And this is the patient's result here. Bacteroides fragilis is a little bit higher, Bacteroides pectinophilus a little bit lower. Let's take a look at the next page here. We can see the very important, the first thing I want to take a look at here is the very important fecal bacterium proteininitis is very low. So really this patient does need a good amount of soluble fiber to help her. Now, the patient that's on the standard American diet is most likely not going to do well if you start with that 10 grams of soluble fiber per day. Absolutely not. You want to go low and slow because you can see she does not have the bacteria to accommodate that amount of fiber. You want to go low and slow, build up the bacteria, and then feed them the soluble fiber along the way. Because if the bacteria are not there to ferment the soluble fiber, the patient can actually feel worse. You do not want to do that. We can see here, the last piece of information is that the proteobacteria are definitely too high, and then that is inflammatory bacteria. So we want to remediate that standard American diet, move away from the excess fats, move away from the ultra processed foods. That's going to be important. Akkermansia is too high. We're not going to do anything to eradicate that. We're going to balance the other bacteria, support the other bacteria, and then bring these into appropriate levels. For this microbiome portion, we don't eradicate these bacteria. It's about balance, supporting diversity, supporting abundance, things of that nature. The eradication will come later on the report. Here we see this patient's stool chemistries. We are looking at the markers of digestion and absorption. That's the first piece of information we have. This actually looks very good. Her elastase is very healthy. There's no fat stains, so gallbladder looks very healthy. Her fat, that looks good. Negative for carbs, no markers of inflammation. So the gastroenterologist may have already ran these. Lactoferrin and calprotectin, those are within range, so that's healthy. Secretory IgA is on the lower end of the reference range, so something in the back of my head I would think about for the patient is her status of vitamin D, very common deficiency. The next piece of information we have is the short chain fatty acids. We saw butyrate is low. We saw those total short chain fatty acids are low. We definitely want to support them with the fiber feeding approach. So that's going to be very important. Consider those dietary considerations at the beginning of the report, because short chain fatty acids are really largely associated with the microbiome information. And then the pH is within range. There's no beta glucuronidase and no occult blood. So that's healthy. Our second report is a 26-year-old female. Now this individual, again, presents with similar symptoms, history of GI disturbances, no specific diagnoses. This individual did find out about intestinal permeability because it's kind of a popular thing on social media these days, and she thinks that she has that. So let's find out. Let's take a look at her information. Very different web here. We can see that this is a disrupted web with regards to dysbiosis and diversity. It almost looks like a hexagon. It's pulled in. Again, the actinobacteria are lower, the Verruca microba are lower for this patient. We did not see that yet, but the proteobacteria are okay. So it looks moderate. What do we see? The moderate dysbiosis index of 3, and then the moderate diversity of 3. So we want to support this patient. Let's take a greater look here. For the key findings, we can see her butyrate producers are low, the gut barrier protective bacteria outside the reference range, and the gut intestinal health markers are outside the reference range, and then that balance between the gut barrier protective versus opportunistic. We want to support the butyrate producers, the soluble fiber feeding approach, again, 8 to 15 grams per day, go low and slow. The gut barrier protective bacteria outside the reference range. When I see that, I think about mucosal barrier integrity. So I would support mucosal barrier integrity as well. There's many protocols for that. You probably have your own favorite protocol, glutamine, marshmallow, things like that. But recall, mucosal barrier integrity is really associated with that microbiome of makeup. So supporting the butyrate producers and supporting the gut intestinal health markers, that will help to support that gut barrier. So all of these things are connected. Again, the gut intestinal health marker is too low, so you could consider calming that down. And then the barrier protective versus opportunistic are too high, are outside the reference interval. So that's going to lead to potential translocation, autoimmunity, things like that. Let's take a look at the second column. Again, the first piece of information we have is not associated with the preceding, on the left, that first row. This is independent. So the Clostridia difficile is there. That is found via PCR. Toxin A and B detected, that is found via PCR. So this is highly sensitive and specific. It is not the patient's chief complaint. It can be a finding associated with asymptomatic carrier status. 30% of the population is asymptomatic carrier for C. difficile, and it can be associated with a resolved infection. So that is not the chief complaint. The next finding we have is carbohydrates detected. Now, carbohydrates in the colon can be a result of malabsorption, but this can also be a result of intestinal permeability. With the finding of gut intestinal health markers outside the reference range and carbohydrates detected, I do think about intestinal permeability. This is not a direct test for intestinal permeability. For that, you would do the zonulin test available in fecal zonulin and serum zonulin. I would get that information, but you do have some findings that you can help the patient with here. Another finding that is associated with that is going to be low secretory IgA, and the patient has high beta glucuronidase. So that higher beta glucuronidase is going to signal us to understand her consumption of potentially charred meats, increase her consumption of vegetables, and also think about hormone status, very important as well. Let's take a look here. Again, for this patient, we're taking a look at the Firmicutes, and we are seeing that that fecal bacterium is very low. And then these bacteria that are associated with mucosal barriers, such as that Ruminococcus navis, that is too high. So we have a very imbalanced here microbiome. Let's take a look at the pathogens here. We can see that C. difficile is positive. Again, this is very sensitive and specific. It does not equate to an active infection. You need to consider the patient's history as well, history and presentation. And with regards to the digestion and absorption markers, elastase is very healthy. Fats are none, so that's healthy, but then we do see those carbohydrates. So this would be a good patient to follow up with a zonulin test and see where they're at. You can also start treating the mucosal barrier integrity as well, and think about remediating the junction barrier. You're going to do that with the microbiome and your nutraceuticals. You can talk to the patient about stress and things like that. Of note, we do see again that low secretory IgA, so that can be associated with that decreased mucosal barrier integrity. Vitamin D I would look at as well. I would think about stress for the patient as well, because chronic stress can play a role here. And chronic stress is also a factor with regards to mucosal barrier integrity. It can induce mucosal barrier integrity and dysbiosis. I would pay attention to that as well. The short chain fatty acids are looking great. They're reasonable, that's excellent. And then we see the intestinal health markers. So pH is within range. That beta glucuronidase is too high. So you can consider some supplements like calcium D-glucarate. You can also consider, I would consider hormonal status for this patient, adequate soluble fiber and vegetables. Just a note about beta glucuronidase. This is a marker that is associated with the cleaving of toxins that have been bounded for glucuronidation to be exiting the colon. So the body is constantly binding toxins, including estrogen, hormones, things like that, for detoxification to exit via the colon. Beta glucuronidase is an enzyme that cleaves that. Now it's always there, but when it's too high, that is a signal that potentially there are increased toxins available in the colon, and then those would be available for systemic circulation. So reuptake into systemic circulation and estrogen as well. So again, I would think about estrogen status in this individual. Occult blood is negative. Just a quick note too about occult blood, that's upper GI. So occult blood is different than RBC. RBC is fresh blood in the colon. All right. And then our last case here, this is a 22-year-old male. So this chief complaint of this individual is diarrhea. This is a very stressed individual, very stressful internship, working very long hours, and just kind of dealing with loose bowels, chalking it up to the stress and just his busy schedule. Let's take a look at the GI360. First piece of information we have here is the web. Again, different web. So with regards to diversity, it looks like it's skewed towards those proteobacteria. That's in a little bit of inflammation, I think, about there. The actinobacteria, the verruca microba are lower. So I would consider supporting that, supporting the substrates there, the fibers, and for the bacteroidetes as well, and then the polyphenols and vegetables. Now I think about the proteobacteria a little bit higher. So this stressed person that's working 16 hours a day is eating a lot of fast food. So we want to decrease that. Now, with regards to dysbiosis, the score is 2. So this is not a dysbiotic gut. Diversity is lower, but we already know we're going to increase that. Okay. Next piece of information we have are key findings. Now, even though that web is outside the reference interval, the key findings, those functional guilds, it's not yet influenced those functional guilds. So those functional guilds are within reference range. That's promising. So let's take a deeper dive. The next piece of information is that second column. We see that the percentage of valerate is low, beta-glucuronidase is low. Now, low beta-glucuronidase does not have the same clinical implications as elevated. Lower beta-glucuronidase may be associated with low microbiome diversity, so there's nothing to do directly there. But we do see that there is a Klebsiella, and they're cultured, and there is the Providentia. Now, Klebsiella can definitely cause the symptoms that the patient is dealing with. So this is a dysbiotic bacteria. We want to eradicate that, okay? When we look at the other markers, additional markers, we do see some yeast under the microscope, but the rest of the markers are within range, so that's excellent. And then when we take a look here, we do see that the pathogenic bacteria are within range. There's nothing there. The imbalanced bacteria are very within range. The Crinibacterium, the Staphylococcus, I mean, these are very common bacteria on the skin microbiome. We see them in the colon here. And then the dysbiotic bacteria, that Klebsiella and those Providentia, those are there, and you do want to treat them. So that's going to be the consideration. There is really eradicating these dysbiotic bacteria. Digestion and absorption markers are really okay. There's nothing to do really for the stool chem information. That percentage valerate, that's going to be remediated. So just a quick note, we're monitoring the absolute value of butyrate here. That's a very important number. Total short chain fatty acids as well, that's an important number. And then this is a balance here. So this is the percentage of these short chain fatty acids in relationship to the others. We did see there's lower diversity. There's some phyla pieces of information to intervene at. So I would do that and expect that to remediate this balance, because again, the short chain fatty acids are associated with bacteria. Here we have the sensitivities for the Klebsiella. Again, you have your choices of prescriptive or natural agents, okay? So those are your options there. We see high sensitivity here for caprylic acid and uva ursi, so you want to choose from the high sensitivity category. And then for that Providentia, again, you have good sensitivity for uva ursi and then ionic silver. So you have options there, and you do have some options with the prescriptive agents. Again, this is for the isolates in your patient's sample. This is not wall charts, so this is unique to your patient. All right, well, thank you so much for that portion of the discussion today. And any questions?
Wonderful. Thank you so much, Dr. Malkowski. That was amazing. I personally really enjoyed the case examples that you were able to share. I want to just open this up to questions. There are just a couple that are that I have on here. And this is open to either yourself or Dr. Sedano. So first question, can fecal secretory IgA be falsely lowered?
Falsely lowered? Oh, do you mean if it's elevated, are there things you can do to lower it?
Yes.
So
I think so.
With regards to that, Dr. Sedano might have another piece of information. When it's elevated, you want to find the cause of the elevation and treat the cause of the elevation.
Yeah, I found, hi doctor, it's a wonderful presentation, thank you. Yeah, I found a couple of things that clinicians need to be aware of that can actually lower fecal secretory IgA and pancreatic elastase as well, and that is having a diluted or watery loose stool sample. It will lower those values. So it's a good idea to question your patients what kind of sample, and you will see that on the report, looking for the consistency. So those two things, just be aware of that.
Point. Thank you.
Thank you. All right. How about this one? Is there a difference between culturing and microscopy?
Yeah. So culturing is where the stool is put in different growth media, aerobic, anaerobic, there's about 12 different conditions, and then what is in that sample will be grown out. And then microscope is where you have a microbiologist or a parasitologist looking under the slide, looking under the microscope slide, just like we've all probably done in science at some point.
Thank you. This is a good one. Is this test available and appropriate for infants under the age of 12 months?
So that's an excellent question. With regards to pediatric populations and especially infants, we do see some differences in their sample, in their reports. Breastfed infants will actually have potentially lactoferrin and calprotectin in their stool. Now, with regards to that microbiome abundance and diversity portion, there's there is some data for pediatric populations, but that microbiome abundance and diversity portion is really well studied in adults. Yet with that culture portion of the report, that is going to show what's cultured in the sample. So this is going to be equivalent for infants as it is for adults for what cultures. And we do know that infants that are born via C-section tend to have a different microbiome than infants that are born via vaginal birth, and that's due to the vertical transmission of the microbiome. And in those infants that are born via C-section, we tend to see Klebsiella and things of that nature. So the culture section is going to be of great information, but some of the other findings do need to be interpreted with care based on the findings.
Great. Let's see if I have anything else. Can you review how culture versus microscopy gives information about the presence of SIBO?
So this is not a test for SIBO. It's not a test for the small intestine. But I will say that in patients that have presentation of SIBO, we have seen dysbiosis. So sometimes in patients that present with SIBO, they do have dysbiotic gut. I mean, another thing we can't test for here is, colonic motility, peristalsis, that might be associated as well. But this is not a direct test for SIBO, so maybe Dr. Sedano has a better information.
I say if the signs and symptoms fit for SIBO, go ahead and test for it. Doing the urea breath test would be helpful. Or I'm sorry, that's for H. pylori. I was stuck on H. pylori today. Doing the breath test, we have several at Evexia, one by a company called All Clear, which is a wonderful test to consider. We also got to think about food intolerance as well.
Thank you. Thank you both so much. All right, Dr. Malkowski, let's go to the next slide, and we will just follow through with a few last slides, and we can wrap this up. Just want to ask the doctor, of course, Dr. Sedano, on any help with lab interpretation, questions on clinical conditions, any support with reviewing any of that, questions specific on microbiome. Feel free to reach out us on the left-hand side of your Evexia portal under the Ask the Doctor. Email consultation is absolutely free. Otherwise, you can sign up for a live consultation. And next slide. And now that we've learned about GI360, I'd like to review how to order any testing mentioned in the presentation before concluding the webinar. First, you will need to log into your Evexia account and go to Evexia link ordering, which is located in the left-hand column of the dashboard. Then you can select or create a patient to assign the test to. You will find these under the specialty lab section. Locate and select from doctor's data the test, and you can find GI360 from that menu, and finally complete the test order by clicking on the green place order button. It's just that simple. And the final slide of the evening. For any questions or issues, you may contact Evexia Diagnostics by email at info@evexiadiagnostics.com or by phone 5 days a week at our extended hours, 8 a.m. to 8 p.m. Eastern Standard Time at 888-852-2723 or live chat. Thank you so much, Dr. Malkowski and Dr. Sedano, for this informative presentation. A recording of this webinar will be available by email in the next few days. So thank you again for joining us for this webinar event. Until next time, from everybody at Evexia Diagnostics and Doctor's Data, stay healthy, stay safe, and we wish you all the best on your pathway to wellness. Good evening, everyone.
Thank you.